Lecture in clinical decision making. This one, in the first lecture we talked just about decision making in general. This time we're talking specifically about decision making in medicine. Um, let's get to it. The objectives for this lesson is to understand the importance and complexity of decision making. So we want to know why it's important and just understand that it's a really complex, complicated process. Um, we can understand the different things that affect clinical decision making, like our biases and our ways of thinking. We're going to talk about the difference between clinical versus actuarial prediction, and so we'll get to that later. And then also we'll have some cases to apply what we're learning. Um, so the decisions in clinical decisions in medicine are especially important because they really have a direct impact on human health. We can actually like save a life, or we can help someone significantly, or we could really seriously harm someone or kill them based on the decisions that we make. And so we're really at I always feel like God has put us in a very special place in people's lives, and we can really have a very positive or a very negative impact based on the decisions that we're making. Um, Also, the amount of times that we're making clinical decisions, like we are making this really critical decisions really quickly and really frequently. So, like every minute, every couple minutes when we're with a patient, we're making a decision. And a lot of times we're having to make those decisions just like really quickly without having a lot of time to be able to think about it. And those decisions that we're making very quickly and very frequently, they're very important. Um, and so it's a big deal, like that if we have these really important decisions we're making, we don't have a lot of time to make them, and we're making a lot of these decisions, it leaves open the room for these mistakes possibly being really big. There's also, we say, ethical and legal implications. And so, um, just like what I was talking about, this is God has put us in a really specific place. People come to us, they're scared and they're sick, and they're have a lot of fears. Um, it's a really important place where these are really vulnerable people, and they're asking us for help. And so the ethics behind that is we really have a big responsibility to help people. And this is the job that we signed up for. So I think I've told some of you before, if you don't want to um, have people complaining to you a lot, and if you don't want to deal with a lot of people that are sick and not feeling good, you should go find another job. um, because this is a really um, big place that we've been put in, and there's a lot of responsibility that comes to it. Um, the other thing is there's a lot of legal implications. Like if we make a bad decision, whether we give the wrong medication, or we miss a diagnosis, or we do something wrong in surgery, we could get sued. Um, uh, Maybe that's less common in Jordan than in the West, but there's still a lot of other things, like with maybe family being really mad at you and being wanting to um, take revenge on you, maybe even if you make a mistake. So there's a lot of um, important factors that show why clinical decision making in medicine specifically is such a big deal. So why do we study this in medicine? So yes, it's a big deal, but what's the importance of studying it? Um, the big thing is that medicine is a science, yes, but it's also an art. There's a lot of things that are uncertain about what we do. Maybe there's uh, a patient that just will refuse to take their medicine. Like, there's no textbook that is going to teach you how to convince a patient to take their medicine. So it's kind of like an art. Maybe we have a reason um, uh, for wanting to prescribe a certain medicine, like maybe we want to prescribe insulin, but the patient refuses to take insulin. And so what are we left with? And so a lot of times, and even if there is a medicine, sometimes there's a medicine that's new that doesn't have a lot of great evidence for it. Or maybe the medicine helps some people, but it doesn't affect other people. So there's so much uncertainty. It's really an art as well as a science. Um, it's a science because we do have a lot of information about why we're doing, but it's an art in how do we take that information and help a patient with it. So it's very complex. We've kind of mentioned that. And we're also making decisions that have a big impact on individual patients, but not just individual patients, but like society as a whole, like our populations. Like when we decide as a medical community where to build a hospital, where to build a clinic, even as an individual doctor, where do I work? Do I work in Abdoon at a really nice clinic where there's 50 other doctors around me? Or do I go to, you know, somewhere in between a little town between Tafila and Kerak where there's no other doctors? There's a lot of decisions that we make um, uh, that impact not just individuals but the society as a whole. When do we make medical decisions? We're always making medical decisions. We make medical decisions when we're diagnosing patients. We make medical decisions when we're deciding which uh, labs or x-rays to order. Again, with the diagnosis, like what questions do we ask? What areas of the body do we examine? When we're treating them, what medicine to give them? What therapy to order? What referral what type of doctor to refer them to? What type of surgery to do? Follow up, do they need to follow up tomorrow? Do they need to follow up in a month? In 6 months? How do we allocate our resources? Like we only have a certain amount of time, there's only a certain amount of money. So, how do we best allocate those resources to help the most people? Um, Administratively, as well, like how do we run our clinic? Where do we put our clinic? How many staff do we need our clinic? There's so many decisions that we're making in all different areas. So we talked about some of these already. So just different difficulties um, that come up when we're trying to make decisions in medicine. Like we said, the decisions are really complex. A lot of times there's not one right or one wrong answer. A lot of times there's, like we say, a gray area, like mish aswad, mish abyad, huwa sakani, like a gray area, like in between. Like maybe this is okay for some patients, but not okay for other patients. We have our time and financial strains where um, uh, maybe there's 10 patients that are still waiting to be seen, and it's already 4 p.m. or already 5 p.m., and we need to go home soon. Um, a lot of times, the decisions that we're making, it involves more than one person. Maybe like we order a test, but then we need to make sure that the lab is a good lab. The person at the lab knows how to run the test. The person that's typing the lab results into the computer is typing it in right. Um, so there's a lot of different things that can affect the outcome of a decision. There's so much medical knowledge that makes it very difficult because medical knowledge is always changing. Um, it used to be, 70 years ago, um, penicillin was invented. And now we have, I don't know, we have thousands of different medicine. How do we know which is the right medicine to use? It's changing rapidly always. Um, and there's still a lot of things that don't have good studies, like maybe a new medicine or a new surgical technique, and we don't know. Like we don't fully understand what is the best surgery to do, or maybe we don't understand fully why this medicine works. We know it works, but we don't understand why. Um, so there's conflicts a lot of times between um, uh, uh, the medical knowledge that we have, but as well as like the general approach to that different doctors have. And so like there's maybe new medical knowledge that comes about, but people have always done it a certain way. It's very hard to get people to change the way they're doing things. And a lot of times, too, there's conflicts between doctors and patients. What do they think is important? The doctor might think that um, treating the patient's cancer is the most important thing, but the patient maybe just wants to, like, doesn't want to go to any more doctors. And so there's a conflict there. In the When we look at this, we see there's a big difference between the ideal world and the real world. And so in the ideal world, we would make all of our decisions objectively, where it's like uh, we have a good reason for why we do this. We think about the problem logically, and we decide this is the best way to solve it. But in the real world, a lot of times we make just very subjective decisions, like why did I, um, even the big things, why did I marry this person? Like, oh, because I love them. And a lot of times it's not an objective decision. Oh, because this person has this much money and they live in this area, that's why I married them. So a lot of times in the ideal world, we'd love to have a full set of evidence, but in the real world, a lot of times we don't have a complete set of evidence. We don't have all the reasons why we're giving. Uh, what's a good example? Like if there's a new medicine and it's been approved, but it hasn't been studied for people over the age of 70. Okay, we know it's good for people under 70, but it hasn't been studied for people over 70. So do we use it, or do we not use it and wait for those studies to come out? In the ideal world, we would just have endless resources, like in an endless amount of time and an endless amount of money. But I don't know if any of you have um, an endless amount of money. Like you could just spend money forever and you would still have more money. I don't think any of us has this. So especially when we're thinking about some costly surgeries or medical procedures for patients, if they can't afford it or there's just not, if maybe it's not even available in the country, um, sometimes we're stuck with what we have. And of course, the time we're trying to help the most people, um, but there's only a certain amount of people we can help. Like if you try to see 50 patients in a day rather than 20 patients in a day, maybe you end up helping no one because you didn't spend enough time with each person. So we need to figure out how can we help the most people, but still do a good job. Um, Also, a lot of times in the ideal world, we would have no interruptions to things, but in the real world, there's so many interruptions. We're seeing a patient, and uh, someone else is knocking on the door, or the phone rings, or it's hard to find a time to just really focus on the problem. So we're going to talk about different things that affect decisions. We're going to talk about patient-related factors, provider or doctor-related factors, and system-related factors. So the first one, patient-related factors. So let's just compare these two examples. One is a 25-year-old male. He's an atheist. You'll see later why I'm adding all this information in. Um, he's so he's the patient. He's sick. He goes to medical school, and he's just recently diagnosed with a brain tumor. He comes from a really wealthy family, and his father is a doctor. He's a very anxious person, and is very very organized. He lives with his parents and his siblings. So let's contrast that with a different patient. She's a 75-year-old poor Syrian refugee woman. She's Muslim and she's diagnosed with a brain tumor. She, in general, is a very depressed person and just very, very disorganized. And she actually lives by herself. None of her family lives, let's say she lives in Jordan, and none of her family is here with her. So, how do you think that these two patients would respond to the diagnosis of a brain tumor? They both have the same diagnosis. How would each one respond? You can kind of think about that for a minute. I wish I could have you in a classroom so I could just ask you. Um, so, some of my ideas, for someone that's 25 years old, um, especially a person in medical school that's very organized, they're still seeing their whole life is in front of them. And they're going to say, hey, I'm going to do anything I can. I'm going to read about this problem. I'm going to go see a lot of doctors. I'm willing to take any medicine just to get rid of this cancer. He has a lot of support around him, and so his whole community, his parents and his siblings and friends, are going to be encouraging him. They're going to be visiting him. They're going to be writing him letters and encouraging him to get the best treatment for his brain tumor. Um, uh, Maybe the 75-year-old Syrian woman. This could be, maybe it doesn't have to be this way, but I mean, it sounds like she's depressed and she's disorganized. She lives by herself. Maybe she just wants to give up. Maybe she says, "This is it." Like Allah bido hek fa khalas. Mara hazur doctor ana khalas. Maybe she just thinks like this is her time to die. This is what God has written for her. Um, and um, maybe she's just kind of done with life. She doesn't have anyone around her to encourage her um, or anything like that. So I don't know. Maybe a different 25-year-old would respond very differently. Maybe the 75-year-old is a very strong woman and she's going to do anything to get better, and she's going to use her faith in God to encourage her even when she's feeling sick, to keep fighting and keep living. Um, I don't know, but regardless, these patients are going to respond probably very different. So these are some of the things that we just talked about, like if the socioeconomic status, if someone's very wealthy or very poor, um, maybe the poor person is more likely to say, I can't do anything. The wealthy person knows that they could afford more treatment. Someone's ethnicity maybe would affect things, their age, their gender, just other personal things about them, like how organized they are, um, or like that's going to affect their prognosis. That's going to be affect their likelihood that they're going to get better if they miss appointments a lot, or if they miss a lot of their medication. Um, Even like wishes and preferences. Maybe one person prefers to take all the medicine that's available. Someone else doesn't want to take any. Attitudes and behaviors. So someone's uh, maybe doesn't even believe in that medicine is good or that it works, and so they're maybe not going to take the medicine. Someone that's very worried or not worried, um, uh, and so is going to really maybe change um, their treatment and other things. Faith, culture, how they view quality of life. Do they have family and friends around them? Um, all these things can change the prognosis for someone. Is going to change the way that someone makes decisions when they are diagnosed with a disease. Um, go over the physician-related factors. And so let's think about it from the physician's point of view. So there's a 30-year-old male physician. He's very healthy. He exercises all the time. He eats well. He doesn't take any medicines because he's so healthy. Uh, and then in walks a 50-year-old obese female who's just been diagnosed with diabetes. So this very healthy young doctor is seeing a older, overweight um, female that's been diagnosed with diabetes. The doctor is an Arab and the patient is Jewish. So the doctor also has 5 patients waiting to be seen after this patient. Um, so let's compare that to a 50-year-old physician who she is the physician is obese, she smokes, she has diabetes, she has high blood pressure, and then at the same time in walks a person very similar to her, a 50-year-old obese female patient who has just been diagnosed with diabetes. Both of them are Muslim, and the doctor also has no one in his waiting room, or no one in her waiting room to be seen after this patient. So um, it doesn't have to be this way, but perhaps like the 50-year-old, she might be more understanding of this patient because she has diabetes. She can talk to this patient and tell her, I was very scared when I got diabetes as well. But I learned that if I take the medicine every day, I don't really feel that bad and it hasn't affected my life that much. She can have um, maybe she may or may not have more compassion on her because they're of the same age, because they're both overweight, maybe because they're both from the same religious background. And maybe she also has more compassion on her because she has no patients waiting. She just has time to spend with the patient. Versus this doctor who has 5 patients waiting, maybe he's thinking, oh no, I need to finish all of these patients before I can go home. And he lives his life so healthy. And there's this 50-year-old patient she's overweight. It doesn't, maybe in his opinion, she's not taking care of herself very well. Maybe he has some bad views of Jewish people. And so maybe he's not going to treat her as kindly because of that. There's a lot of different reasons that could make his treatment of this woman not as nice as this physician. It doesn't always, like I said, it doesn't always have to be like this, but I'm just giving you some different examples that show what are the things that might change might affect the way a physician is treating a patient. So a lot of it is the same. Age, gender, culture, faith, race, all of these things like we talked about in the example before. Also time constraints like we mentioned, if someone's very busy versus they have a lot of, they're not very busy in their clinic. Also, these other ones, we didn't mention this as much in the example, but the doctor's relationship with his colleagues and the hospital staff might also change things. In the relationship with the pharmaceutical industry, like a good example of that is if a person from a pharmaceutical company or a drug company is always taking the doctor out to nice dinners, things like that, always giving him gifts, it might be more likely that the doctor is going to be biased and is going to be more likely to prescribe certain medications because he has a relationship with the pharmaceutical industry. Um, maybe regarding the colleagues and hospital staff, if the doctor has a lot of trust in the nurse that is working with him, maybe he will let the nurse give all the patient education about diabetes. But if he doesn't have a lot of trust, maybe he will do it all on his own. So it'll just change the way that he's making the decisions. Like if a doctor in the hospital doesn't trust that a nurse is going to give the medication properly, he might give it himself. So just whether that's right or wrong, I'm not saying that. These are just things that can affect the way that we're making decisions. Last topic here is the practice related factors. And so let's look at this example. It's a 50-year-old patient with 1 week of chest pain. He comes into a small private clinic in Abdoun versus the same patient, a 50-year-old patient with 1 week of chest pain, comes into a very busy, very crowded, large government clinic in Mukhayyam Baga, the Baga camp. Um, what's going to be the difference in how they're treated here? I mean, my guess is the person that goes into the small private clinic in Abdoun is probably going to be um, get more tests done and the doctor is going to probably spend more time with this patient. Even if the same doctor is at both places, he's probably going to spend more time with the patient here. He knows the patient is paying cash, the patient has higher expectations, maybe at the smaller clinic, maybe the doctors and patients know each other better. Um, but at a very busy, large government camp in Baga, um, they're, forgive me if I'm saying that wrong, um, they're going to be just the whole way that the patient is treated at the clinic, not just by the doctor, is going to be different. And so we see this, the things that can affect treatment depending on the practice. Maybe if it's a private versus a public, maybe the size, if it's a big clinic or a small clinic, how well it's organized. Do they have like a very well run appointment system, or do they just let patients come in whenever they want? Um, uh, the location, obviously, and availability of health resources. You know, if you're going to see um, a doctor in Aqaba versus Amman, there's just a lot different things that are going to be available to you in Amman. And lastly, just the management policies, like the way that the clinic is even being run, as well as the cost at different clinics. Sometimes, like the same treatment um, or the same thing at two different clinics is gonna have a different cost to it. Okay. Um, the so if we just break things down again, so we kind of talked about the patient-related factors, doctor-related factors, practice-related factors. Now we're going to look at it from a different angle and just say just factors that affect any individual, doctors, patients, anybody, when they're making decisions. So we're going to talk about the values of a patient or the values of any person, sorry, the life experience of that person, the preferences of that person, and just that person's way of thinking and of making decisions. So when we talk about our values, um, we're talking about anything that's just really important to us. It could be our beliefs, like religious beliefs or personal beliefs about anything, and really like all our decisions are based on our own values, like whether that's consciously or subconsciously. Like if I uh, hate old people, for example, even if there's if there's a decision that I'm making, um, whether um, I might not be thinking in my mind, like, I hate old people. Because of that, I'm going to do something mean to this person. But if I hate old people, I am, even if I'm not trying to be mean to them, I'm going to be way more likely to be mean to them. So my value about that I don't like old people is going to affect the way I treat them, even if um, even if I'm not meaning to treat them that way. If that makes any sense. So it could even be in the subconscious, is what I'm saying, or it could be consciously. Like, I'm treating this old person mean because I don't like him. So my value system is um, uh, making me treat someone or make a decision in a certain way. So our values also affect the way that we're gathering information, the way that we process information, meaning like the way that we think about the information, as well as the final outcome. So, for example, if in the medical setting, if I'm afraid that a patient might be mad if I ask them about sexual intercourse and taking their sexual history, I might miss the diagnosis of an STD. Like, so say a woman comes in, she's having some vaginal discharge. If I'm really afraid and I think, um, I can't ask women about their sexual history, then there's no way that I'm going to make a diagnosis of an STD, like of a sexually transmitted disease. So my value is that I should not ask women about their sexual history. That's going to change my entire process of the way that I'm making the decision on what this patient has. Um, it's going to limit the number of alternatives generated and also the final choice that we select. So um, if if someone comes in to my office and they're depressed, there's in my mind there's different options that they have. I can give them medicine. I can refer them to a psychiatrist. I can send them to a psychologist or a counselor. I can talk to their family. I can encourage them to exercise and eat well. There's a lot of different things that I could possibly do. These are all the different alternatives that I could choose when trying to help them. But if I don't believe that medicine is helpful to depression, or there's some people that believe that it's actually a bad thing to give medicine to someone with depression, then I won't offer that as an option. And so if my value is that I don't believe that someone should take medicine for depression. Like, they need to change their lifestyle. It's not about giving them medicine. If I believe that, then when I'm coming up with all the ideas of ways that I could help this patient, giving medicine will not be one of those options. So another thing that changes the way that people make decisions is based on their life experience. And so, uh, and specifically when we're talking about medicine, a lot of times we think about like this example of a doctor with 5 years of experience versus 20 years of experience. Um, so, how do you think that uh, a person like so if there's a patient that comes in with like some symptoms like a uh, cough with bloody sputum with phlegm, he's coughing up blood. Um, how do you think a doctor with 5 years of experience versus 20 years of experience would act in this situation? And specifically, I want you to think about it from both sides. How could it help that this doctor has 20 years of experience? How could that help him? Like, maybe you think, well, he's seen a lot of patients like this before. He's um, he's tried things before and seen what helps and what doesn't help. He has talked to a lot of colleagues over the years, and he kind of just really has a good idea on probably what this person has because of all his experience. But I also want you to think about how could this hurt? Like how could his this person having less experience, how could that be a help? And how could the 20 years experience actually be hurtful? Um, One idea that I can think of is that maybe this person, they're more recently out of medical school. Maybe there's a new medication. Maybe there's a new disease that's being diagnosed. And maybe this doctor here, he just hasn't been really like keeping up to date over the last 15 years. Like in the first 5 years, he just got confident and realized, um, I just got confident in what he's doing and thinks that this is what I'm going to do from now on. Like maybe he got older, or he got tired, or something like that. Whereas this doctor right now, because he doesn't have so much confidence, maybe he's more likely to go and read about this patient. Maybe he's more likely to ask more questions of the patient, and he's not going to jump to a conclusion or make a decision as quickly as the doctor with 20 years of experience. And so I'm not saying experience is bad. It could be good. It could be bad. Uh, Another thing is individual preferences. So that's where maybe one alternative is preferred by one person, but maybe the other alternative is preferred by someone else. So this would be based on, um, a lot of times these preferences are really based on personal risk and cost. And I'm not just saying like physical risk. I'm talking about um, maybe someone um, it's physical has physical or emotional risks, or financial costs, or their amount of time they spend on doing something, or how much energy they have to do for something. So, like if someone is overweight and they want to lose weight, um, someone might, and then they start working out for a week. Uh, it's going to make their muscles sore. Um, if they haven't seen any weight loss after 1 week, that's going to be hard on them emotionally. Financially, maybe they paid to join a gym. Maybe they spend 1 hour every day, and then it also like makes them tired because they're going to the gym and they're working out. Maybe one person prefers to do all that, whereas another person that's overweight says, that's just too much cost, like financially and time and physically. Like I don't have the energy to do something like that. So they're going to make a different. So they might have a different preference. Their preference is they don't want to spend all this time and money and energy to lose weight, whereas maybe someone else does prefer that. Another example is like someone that would like to do a surgery now versus delaying surgery. Like maybe a medical student would prefer to delay his surgery till the summer, or maybe a person would rather try medicine rather than um, rather than doing a surgery because they have fears. So another like emotional risk. Like if I do this surgery, I have a fear about it, and I would have to face my fear to do the surgery. Versus if I delay the surgery, I don't have to worry about that for right now. So a lot of these things, it's not about whether it's right or wrong. It's about what does that specific person prefer to do. And lastly, here is that different individuals have different ways of making decisions and just different ways of thinking in general. If I don't know if any of you are married, probably not yet, but once you get married, you will see that your spouse, your husband or your wife, um, will think very differently than you about different things, and that's good. Um, but sometimes that leads to some conflict as well. So there's different ways that psychologists have broken down into the ways that we think. One method is systematically or analytical, meaning you think about things very logically and orderly, and you have a reason why you did it. Um, uh, Intuitively means that someone just makes a decision, um, like we say, with their gut, like with their stomach. Like they just, it feels right, and so we do it. So, um, like, why did you choose to wear the clothes that you wore today? um, was it because you think you have a system and you say, I wear blue every Yom L'Ethnain? Or is it like very systematic? Or is it, I feel like wearing blue today just because? That would be more intuitive. And for most things, honestly, we have it's both, um, a mixed picture. So we're going to go to a couple definitions here. We'll say, and this is specifically for clinical decision making in medicine. So clinical prediction is the reliance on clinical expertise and intuition. So it's the doctor that says, oh, this person, this cough, this they have a cough, they have a runny nose. This just feels like they have a viral illness and it's going to get better on its own. This is uh, the way of making decisions that most doctors prefer. Um, One reason is because it's a lot faster, and um, I, another reason is because it just feels right. Another reason is that doctors have a strong belief in the value of their own experience, and so if anything, many doctors have a lot of confidence in their own personal experience that they have had in life, and so they feel very comfortable making a diagnosis based on their own experience, rather than needing to use like a textbook or other evidence to prove them right. Um, Actuarial prediction um, is the use of formulas based on empirically established relations. And so this might be an algorithm that says something like, okay, in a patient with anemia, we order a CBC. If it's microcytic anemia, then we ask these questions or we do these tests. Or if it's a macrocytic anemia, okay, that means we need to order these tests. So these are guidelines that maybe have been come up with by scientists or governments or the Department of Health, that have been studied and verified. Um, uh, and so that's another way of making a decision. Like if a doctor is specifically going to follow the guidelines. Um, but this does not exclude clinician judgments if those judgments have value. So, for example, someone with appendicitis, one of the there is like guidelines that are written, but one of those guidelines says if the patient has rebound tenderness, and I don't know if you remember that is, but that's you push on the abdomen and then you let go really quickly with your hand. And when you let go, does the patient have pain? That's rebound phenomenon. Um, and so there's a formula that we're following, but part of that formula involves something about clinical judgment. And so just because we're using an actuarial prediction doesn't mean there is no judgment involved, or no clinical expertise involved. It just means in general we're basing our decision based off the guideline or algorithm rather than uh, um, just the basic intuition about something. So a little history is that in 1954, um, this guy, Neal, was the first to compare the two different methods. And now we have well over 100 studies to compare these two types of decision-making methods. And evidence overwhelmingly favors the actuarial approach, meaning that uh, it is much more reliable to have evidence, to follow guidelines, to use algorithms, than to base our decisions based on how we feel. And one of the things they noticed in these studies that's really interesting is that experienced clinicians are not necessarily more accurate than inexperienced clinicians. And so, my question for you is why would that be? Like, an older doctor has to be better at um, uh, predicting things than a younger doctor, right? Like, why would that possibly be? So that's the question. Why doesn't experience improve clinical judgment? One reason is because of these things that we will study a lot in this course called cognitive biases and errors. And these are universal to all human beings. And so this does not mean that someone is a bad person or a bad doctor if they have biases or if they are making cognitive errors. We're going to study this a lot more in other sessions, but this is one thing. Cognitive biases, like we might have things that change our judgment, we say cloud our judgment, like that make our judgment less exact, and we might have different errors or problems in the way that we think. Number two is that when we're seeing patients specifically, there is so much information. There's so much information from textbooks and medical knowledge in general, and there's also so much information that the patient is telling us. Like the patient will tell you all of these symptoms and all of these things they're feeling, and you're trying to combine that with all of your knowledge in a very quick amount of time. So, how can we improve? I think this is a really, really important question. Um, I, because it doesn't matter if we just know these definitions, right? Like we want to know, okay, how can we get better at making clinical judgments? Um, how can we get better at making these clinical predictions, or how can we get better at making these actuarial predictions? And how can we get better at just thinking in general? Um, One thing is we need to understand the biases and errors that we're making. And so if we need to understand what things we believe, we need to understand our values and what uh, thinking errors that we are making. And we'll study that a lot more in another lecture. But this lecture, we're going to talk more about, we're going to study, um, we need to study how to think better, meaning we need to study how to think critically rather than illogically. And we're also going to talk some about the idea of reflecting um, on how we think and why we are making decisions, and so that we can improve for the next time. Okay, so first thing, we're going to study how to think more logically, more critically. So critical thinking, the definition is the rational examination of ideas, inferences, assumptions, principles, everything. You don't have to memorize that whole thing. But it's just the rational examination of the ways that we think, the ways that we're talking, the decisions that we're making. It's the word, it's a controlled and purposeful way of thinking, and it's a way of thinking that's more likely to lead to beneficial results. And the definition really of critical is just it's requiring careful judgment. So you have to really think about it hard, like not just quickly without thinking very hard about it. Versus thinking in general, thinking is just like any mental activity. It could be having an opinion about something, it could be remembering something, it could be you have a picture in your head about something, it could be just pondering something, meaning you're just thinking about it, um, but you're not really trying to think too hard. You're just thinking about what a beautiful day it is, something like that. Um, it can be aimless and uncontrolled. Like it doesn't have to be um, to think about a problem or to resolve a problem. It can just be thinking about whatever, thinking about how much you miss your girlfriend or something like that, um, uh, or your boyfriend. So it may serve a purpose, but we often aren't aware of its benefits. Um, like maybe sometimes we're just thinking randomly, and then all of a sudden we realize we like learned the best way to help a patient, but we weren't critically thinking about it. It was just we were thinking about the patient, and then an idea popped into our mind. So sometimes that happens, sometimes it doesn't happen. And a lot of times we might not even remember our thoughts at all. We have so many thoughts that come into our head during the day that we can't possibly remember them all, and so and that's fine. So the different characteristics of critical thinking is that it's rational, it's reflective. Reflective meaning that we're considering why we are making the decision. Um, It involves healthy and constructive skepticism. It means constantly thinking, is this the right way? Could this be wrong? Is there a different thing that I'm missing that I should be thinking about? That's the skepticism. Autonomous, it means that we are choosing to do this. It's not something that's forced on us. It's not something that's just happening randomly. That we mean to do this and we are choosing to do this. It includes creative thinking sometimes. Sometimes it thinks of, well, what's a better way that we could um, uh, study, or what's a better way that we could treat a certain sickness. We have to think, we say out of the box, we have to think of new ideas. Um, Fair thinking means we're being honest. We're not um, like if we should not ignore data. Like if a patient tells us that they're coughing, but we are thinking, but we don't, we think that they have a stomach illness. We need to be honest and say, oh, does this new information, does it change our diagnosis? And then focusing on what to believe and do. So this is really where critical thinking is different than thinking, is that it's for a purpose. Like, what do we want to do? Or maybe it's a belief, like what do we believe about God, or how we should live our lives, something like that. So a good critical thinker, we're hopefully all going to become more and more like that. It examines decisions from all sides and takes into account varying points of view. And so, if someone, say, uh, believes in God, that He exists, but he is not willing to talk to anyone that thinks that God does not exist, and at least to listen to his point of view, he's probably not being a very good critical thinker about it. Or if someone says, this is the best way to do the surgery, but then a new surgery method gets invented, and the doctor doesn't even want to read about it or hear about it, he's not being a very good critical thinker. He's just doing what he's doing and not thinking about it and taking into account different points of view. Um, Also, a critical thinker always generates new ideas and alternatives. So he doesn't just come up with one positive possible alternative. So like when we're coming up with a differential diagnosis for a patient comes in, has a cough, runny nose, and a fever. We need to be able to say, what are the different possibilities? Like if we just say that means he has a viral illness, that's possibly true, but it's also possibly true that he has pneumonia or cancer or a pleural effusion or heart failure. Um, that's all part of critical thinking. And we also they need to ask why questions about a situation in order to arrive at the best decision. Um, so if in that example of it's just about questioning things, So in the example of uh, like someone that believes in God, um, he should ask, why do I believe in God? And okay, my parents said that they believe in God. Oh, okay, because I believe the world couldn't come from nothing, something like that. Why do some people not believe? Like, and try to think about it. In the example of a surgery, um, it would be um, uh, okay, why might this new method be better than the old method? Why would the old method possibly be better? Something along those lines. Um, so for to contrast critical thinking is illogical thinking. There's a lot of different types of illogical thinking, and we're just going to talk about a couple here, and we're going to talk about a lot more um, when we talk about biases and errors and incorrect ways of thinking. So one, you could so if you're arguing with someone, you can try to see if you're uh, using any of these ways of illogical thinking, or if the person that you're arguing with or disagreeing with, um, it doesn't have to be an argument, is using any of these ways of illogical thinking. So one is overgeneralizing, and that is the idea that because something, A, for example, has a certain characteristic, then every other A has the same characteristic. And so this is classic when we talk about racism or stereotypes. So um, if someone thinks that all black people are uh, angry and dangerous, then they are going to be more likely to um, stay away from them, or they're going to be more likely to be afraid of them, or they're going to be more likely to not move into a neighborhood where there's more black people, things like that. But in medicine, you can still see it. Like, uh, where could we see this? Because uh, someone might say someone is overweight, and this person that I know that's overweight is also very lazy. So that means that every overweight person is lazy. So that's going to change the way that I'm thinking about how to help this patient. And so obviously that's not true. Like, not all people that are overweight are lazy. There's some people that are and some people that aren't, and there's some people that are not overweight that are much more lazy than people that are overweight. So another way of illogical thinking, affirming the consequences. So that means, like, so one example, so B is good, but he's not doing A, so A must not be good. This is called affirming the consequences. An example would be like, so a surgeon that you really respect, and a lot of people think he's a really good surgeon, he's not using a new tool or like a new uh, medical device in his surgeries, so the tool must not be good, which is obviously not true. Like, yes, the surgeon, maybe he is good. There's a new tool. Maybe it's good, maybe it's not good, but it's not going to be how good the tool is not based on if the surgeon is using it or not. Maybe the surgeon doesn't know about it. Maybe he doesn't feel comfortable with it, something like that. So also another one is arguing from analogy, and that is because A is present in B, then A and B are alike in all respects. So for example, for medicine, because two patients are both Palestinian women living in the same neighborhood, they will have the same ideas about what their, or the same preferences about the treatment of breast cancer. So they both, so I know this one Palestinian woman that she lives in Arabia, and she was diagnosed with breast cancer. So, and she really wanted very aggressive treatment with a bilateral mastectomy, like to have both breasts removed. So, if I'm arguing from analogy, that means that every Palestinian woman that lives in Rabia that's diagnosed with breast cancer is going to want the same treatment that she got. So think about this when you're disagreeing with someone. What type of arguing they're using or argument they're using, and does it make sense? So our last topic for today is reflective thinking. Um, so that's the idea of just observing oneself as one performs a task or makes a decision. So it's about reflecting. So after we've finished something, um, I, or while we're making a decision, to keep thinking backwards and think about how did that situation go? How did I make that decision? Um, uh, and so when we do that, it allows us to really evaluate how we made the decision and if the decision itself was correct and if the things that our way of thinking was correct. Um, this is really, I mean, we're talking about adult learning here, like this is the ways that after you graduate, this is the way you have to keep learning is you have to, no one else is going to be able to teach you as well as you can teach yourself. So this is a huge, huge, huge important way of growing in your ability to think. And so when we talk in Britain, they're really good at this, actually better than America, although we do this in America too, some people call it morbidity and mortality conferences. Like if there was a bad outcome that happened, then they all talk about it together as a group. In England, as your ongoing medical education, you have to do these reflective papers every few years. And in those, there's three parts. At first, you talk about, so you think about a case that you saw um, that was important to you. Maybe it was a very serious disease. Maybe there was a bad outcome. It could be any case. Um, you write down what happened, what were you thinking, what were you feeling, and what did you do? So, for example, like, okay, there was a patient that came in, they were coughing. I thought it was just a viral illness. Um, I wasn't, I was feeling kind of stressed because I had a lot of people in the waiting room that day. So I told her, what did you do? I told her, you're going to get better in a few days. Just take some Panadol and you'll get better in a few days. So, but then to finish it out, like she came back a week later saying that she was having more chest pain and now she was coughing up blood. And so I sent her to get a CT scan, and it turns out that she has lung cancer. So I felt really um, sad for her. I felt really mad at myself because I missed the diagnosis the first time. This can all be part of the narrative. So the learning. So what did you learn? Why do you think you responded the way you did? Did you do the right thing? Or could you have done anything differently? So I could say for that case, I learned that even though I have a lot of patients waiting, I really need to slow down and focus on the patient in front of me. I think I responded the way I did because it really did seem like a cold, and I've seen a lot of colds. It's the middle of the winter, a lot of these viral infections. It's the middle of the winter. I think I did it because I was just, it really did seem like the right thing. Um, Now looking back on it, I can see that maybe I should have asked her um, some more questions about whether she had any weight loss or any, um, or maybe I needed to do an exam of her lungs and I didn't do that. Um, or maybe you feel like you did do the right thing. And then the last part is the change. What would you do differently next time? I would maybe I'd shut the door in between each patient. Um, Next time, I would make sure I listened to all the parts of her lungs, not just two parts. Next time, I would ask her about if she has any hemoptysis or blood in her sputum, something along those lines. You get the idea. This is an example of a doctor that was doing one of these medical reflection papers. So I just wanted to give you an example of this. You can kind of read it. There was a he says, when I meeting a man living with HIV and listening to him discussing his illness really shocked me. and made me remember the reason why I chose to become a doctor. This experience helped me when I met a girl with cystic fibrosis. The girl said that she knew there was not much time left for her, meaning that she's going to die soon, and there was not a lot doctors could do for her, so there wasn't much else that doctors could help her with. This made me feel angry and sad because I really wanted to help her, but I knew I couldn't help her. Doctors should be able to understand. So that was the first part, the narrative. Doctors, and this is his the learning part. Doctors should be able to understand the impact of illnesses on patients and their families. These two experiences have certainly given me a small insight into the value of life and the impact of illness on patients and loved ones. I hope in the future. So there's his learning, and now that he's going to talk about the future and what he hopes to do. I hope in future practice I will not forget this lesson and ensure that I always have time for patients and that I will treat them as people and not as illnesses. So he kind of has all three parts in there. So these guys are coming up on this sign, that says stop and think. And then the person turns next to him and says, it sort of makes you stop and think, doesn't it? I don't know if the joke translates for everybody. Okay, so let's go a couple examples before we end here. There's a 32-year-old male patient. He was admitted with right iliac fossa pain, meaning like right lower quadrant pain, right in his abdomen, for one day. When you examine him, it indicated that he has a lot of tenderness in that area, and the rebound sign was positive. And like I said, you push, you let go quickly, and he kind of like jumps, like he has pain when you do that. Labs showed a normal white blood cells, and the abdominal ultrasound was negative. So the main question is, does this person have appendicitis? Because if he has appendicitis, he needs surgery now to get it out before it bursts. What do you think? And more importantly than that, for this course right here, this lecture right now, is that how did you decide that? Did you decide it based on, well, I read this, and right when I read it, I just felt like he has appendicitis? Or did you make that decision based on going to read about appendicitis, talking to other people about appendicitis, really thinking through each thing? Okay, he's 32. Okay, does his age have a factor? He's a male. Does that increase or decrease the risk of appendicitis? Okay, he has right lower quadrant pain that's been going on for one day. Okay, does the location, does that mean appendicitis one day? Do most people have symptoms of appendicitis for one day, or is it just hours, or is it days? Okay, what about if someone has pain there and then the rebound sign is positive? How much does that increase or decrease the risk of appendicitis? What about a normal WBC count? Well, I know sometimes people with appendicitis have high white blood cell count, and okay, but the abdominal ultrasound was negative. How much does that increase or decrease the risk? If you did that, that's critical thinking, or this actuarial approach. If you did more of the first one, that's the intuitive approach. So just to help us think through it in a more critical way, is you'd ask questions like, well, how would I explain a normal white blood cell count and normal ultrasound in a patient like this? How would I explain it? Would your So when you're deciding what to do, this person's going to get surgery or just wants like medicine or whatever. When you decide what to do, what does it change what you would do if the patient is really scared of doing the surgery and just wants medical treatment? Or does that not change your decision? And then what about if another colleague of yours who's a surgical resident, so he has a little more experience in these kind of cases, thinks that the rebound test tenderness was negative? Does that change your decision at all? Like if you decide like he has appendicitis, but one of your big reasons was that there was rebound positive, um, and now this surgical resident doesn't think there was rebound tenderness. Does that change your decision at all? Just going through the process of thinking, how am I making this decision, and think about each item carefully. That's what we're trying to start at. And we'll go over more of like methods on how to do differential diagnosis, how to do problem solving. But for right now, the main thing is, are we thinking about it critically, or are we just making the decision very quickly? And I'm not even going to tell you the answers to all those questions, because some of the answers, it's a tricky thing, um, and a lot of times a doctor might make the wrong decision, but it was the best decision that he could have made, even if and he was thinking critically. So another example is a 44-year-old pregnant female. She's in her first trimester. She had a blood screening test done for Down syndrome, for trisomy 21, um, and was told that she had a 1 out of 50 chance risk of having Down syndrome, or the baby has a 1 in 50 chance of having Down syndrome. And the normal range for someone her age is 1 in 300. And so she has about a 6 time higher chance of having a baby with Down syndrome, um, with than someone her age normally does. So she comes to you. She's very anxious. She's very stressed. She doesn't know whether she should do an amniocentesis or chorionic villi sampling, or proceed with just having an abortion. Um, but she does know that she really, really does not want to have a baby with Down syndrome. So, what would you do? And how do you decide that? So, um, I mean, you can say you can't have an abortion, it's illegal. You could just tell her that really quickly. You could ask her more questions. You could um, uh, give her all the different options and say, hey, you just have to choose. There's a lot of different things you could decide to do here. And do you see that based on your values, um, it might change the alternatives that you even offer to her? Um, I mean, you could get really angry at her because she wants to have an abortion because you don't believe abortion is okay. You could uh, lecture her and say, no, 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 you can't get an abortion because of this, this, this. Um, if you had uh, maybe a child or a family member with Down syndrome, maybe you would be very soft with her and you could say, hey, I know this person with Down syndrome and they are so sweet and so caring and so loving. Um, or maybe you could just listen to her too. So, but the main thing is, what do you do now, and how do you decide what to do next? Like, do you do it just based on how you feel, or are there any guidelines or any recommendations from the government or any algorithms that you could follow to help you make your decision? Um, and even if there's not, are you thinking about your decision logically and carefully? And even with this, are there any ethical, are there any legal, are there any social applications for this? Like, is there any law that says abortion is illegal? Because that's going to affect how you make your decision. What about ethically? Like we mentioned, if you believe that ethically abortion is wrong, that's going to affect what you do. Um, and just in general, the way that your society around you thinks. If they're very okay with it or if they're not okay with it, that might affect the way that you make decisions too. So this is my homework for you, is to, and I want everyone to send me this this week, is to, it doesn't have to be long, but I just want you to go through the process of reflecting a little bit. So think about a time when one of your family or friends was sick. I want you to write what was the situation? Who was sick? What did you do? How did you feel? Were you scared or depressed or anxious or mad or annoyed by them? Any of these things. Um, and then I want you to say, like, what did you learn in the process? Like, why do you think you responded the way you did? Did you do the right thing? Like, if the person was sick, like, did you help them? Did you not help them? And then why do you think you helped them or did not help them? Now, looking back, did you feel like you did the right thing or you did the wrong thing? Like, should you have helped them more? Could you have done anything differently? And then what would you, the next thing uh, is the application or the change that you want to make. What would you do differently next time if someone else, one of your friends or family, gets sick, or uh, what would you hope to do differently next time? That's your homework. So send it to me via Microsoft Teams, um, and uh, and I'll look at it.